In this next segment, we're going to now trace the median nerve as it travels down the arm, the motor and sensory branches that come off of it, where they come off, the muscles they supply, the function of those muscles, motor and sensory deficits that can occur from an injury, specific places that the nerve can be impinged or injured as it runs down the arm, as well as signs and symptoms of median nerve injury. So we're starting at the beginning. It's going to run down the arm, and it's going to run down the medial aspect of the arm, and it's going to go lateral to the axillary artery, which is going to become the brachial artery. And then it's going to switch as it gets into the distal arm. And to the distal arm, this is where you can have your first impingement type problem, as the nerve is going to run through an osteofibrous tunnel formed by the medial epicondyle, the medial supracondylar ridge, and the ligament of Struthers that connects those two structures. So it runs through that tunnel. Fractures of the medial epicondyle, supracondylar fractures, trauma in this area, that can all cause an injury to the median nerve. This is referred to as a high median nerve injury. If you have it high, it's going to affect everything distal. Everything proximal to it, motor and sensory, is intact. But there is nothing proximal to this injury because all the function, motor and sensory function of the median nerve, is distal to the arm. It's in the forearm and in the hand. So it basically can affect all the actions we talked about. The flexor pronator mass, so you could have weak wrist flexion, finger and thumb flexion, a weak grip, a weak tip-to-tip pinch like this, hand dysfunction. All those can occur with a high median nerve injury, as well as abnormal sensation in the lateral 3.5 fingers and hand. Okay, now as we continue with the nerve, it's going to come out of the osteofibrous tunnel and enter the medial cubital fossa, which is in this area right here, so at the level of the elbow. Just distal to the elbow, right in this cubital medial fossa, it's going to send off 4 motor branches to the nerves that are in the superficial compartment, so your palmaris longus, your flexor carpi radialis, and your pronator teres. Those are your 3 superficial muscles, and the one in the intermediate compartment, which is your flexor digitorum superficialis. So those are sent off very early. Then it potentially could be impinged and injured again as it travels down. Right in this area, you have the 2 heads of the flexor digitorum superficialis. That fibrous arch is formed. It could potentially be impinged there, or as it travels under the bicipital aponeurosis, you get an abnormal thickening of the aponeurosis. Potentially that could injure the nerve if it's traveling in this medial cubital fossa. But more likely, it's going to be injured as it travels between the 2 heads of the pronator teres. So remember, this represents the pronator teres. It has 2 heads, medial epicondyle and the coronoid process, and as it travels between those 2 heads, it can be impinged. Now, if it is impinged, that's called pronator teres syndrome. Now, the 4 muscles I just talked about, 3 superficial, 1 intermediate, they've already been innervated. So that will spare the functions that those muscles do. And so you still have some wrist and finger flexion. You won't lose that, or you could still lose some, but you won't lose it from those muscles. What will you lose? You're going to lose potentially everything distal to the lesion. So what's distal, if it's being compressed between the 2 heads of the pronator teres, the only thing left that it hasn't innervated are the 2.5 deep muscles in the forearm and the muscles in the hand. So the 3 thenar muscles and the lateral 2 lumbricals. The motor-wise, those can be affected. So again, the 3 deep muscles, it's actually going to only innervate 2.5 of them, half, the lateral half of the flexor digitorum profundus. So that again is going to flex the distal interphalangeal joint. And then the flexor pollicis longus flexes the interphalangeal joint. So that allows you to basically do this. And then also the pronator quadratus. That's the final deep muscle. And that's going to go from the radius to the ulna in this direction. It's just a small muscle that helps pronate the forearm at the distal radio-ulnar joint. Okay, so this would be a sign for pronator teres syndrome, but not just this, it could also, if it affects the median nerve, which is a mixed nerve, sensory and motor, it could also affect the muscles in the thenar, so you have dysfunctional use of the thumb, ability to flex, abduct, and oppose the thumb, and the lateral two lumbricals, the ability to flex the metacarpophalangeal joint and extend pip and dip in those two fingers, and sensory-wise, abnormal sensation in the lateral 3.5 fingers, and the hand can be affected. That's pronator teres syndrome. Interestingly enough, a branch comes off the median nerve as it goes through the two heads called the anterior neurosseous branch. It can also be impinged as it's going through the two heads of the pronator teres. This is a C8-T1 motor nerve. So all the muscles it supplies is going to be in that C8-T1 levels, and the muscles it supplies are the 2.5 deep muscles we just talked about. Those are the muscles that do the OK sign, just like this. So if you have an injury to the anterior neurosseous nerve, you have them do the OK sign, which you pronate, and then you flex the IP and you flex the dip. And if they can't do that, that's a positive sign for anterior neurosseous syndrome. And it's a motor nerve only, so there's no sensory. It just affects those three muscles. Then the median nerve is going to continue down the forearm between the flexor digitorum superficialis and the profundus. It's going to deviate laterally and go between the palmaris longus and flexor carpi radialis tendons. And a few centimeters before the wrist, the palmar cutaneous branch is going to come off. It's going to travel superiorly to the flexor retinaculum, right in here, and it's going to innervate the skin in the central and lateral palm. This is important clinically because it goes superior to the flexor retinaculum or the transverse carpal ligament. So it doesn't go through the carpal tunnel. So in carpal tunnel syndrome, the central palm and the lateral palm is spared. You don't have abnormal sensation there. You just have it in the lateral 3.5 fingers in carpal tunnel. Then the median nerve is going to continue through the carpal tunnel, and along with the 9 extrinsic tendons and their synovial sheaths. So remember, you have 4 tendons from the flexor digitorum superficialis, 4 more from the profundus, and then 1 from the flexor pollicis longus. So they travel through synovial sheaths. If you have repetitive use of your hands, your fingers, your thumb, typing all day long, that could overuse those muscles. You can get a tenosynovitis, an inflammation, a swelling. That puts additional pressure on the median nerve, and that can cause carpal tunnel syndrome, causing motor and sensory distal to the lesion. Now, distal to the lesion, all the muscles in the anterior compartment of the forearm have already been innervated by now. So you're going to have good function with these muscles. Where you're not going to have good function potentially in carpal tunnel are the muscles that are distal, which are your thenar, 3 thenar muscles, so flexing, abducting, opposing the thumb, and the 2 lumbricals. That's where you get motor deficits and sensory deficits in the lateral 3.5 fingers. So overuse, especially if they're flexing and extending their wrist a lot, or they have bad position, that can decrease the volume in the carpal tunnel. So a test for it is actually a Phalen's test, where you go hyperflexion like this up to 60 seconds, and that compresses the contents, including the median nerve, in the tunnel. And if you have abnormal sensation in those lateral 3 fingers, that's a positive sign for carpal tunnel syndrome. The earlier in the 60 seconds you have it, the worse the condition. The later, the less severe the carpal tunnel. Or you could do a reverse Phalen's, kind of a prayer position where you hyperextend. That can also compress the contents. Either one of those you can do. So because a lot of flexion and extension potentially could irritate the nerve in the carpal tunnel, a lot of times we splint the wrist, we keep it in neutral, especially when they're working all day long or when they're sleeping, where the wrist can do different things. So that would be one of the ways to get carpal tunnel syndrome. There's other ways, falling on an outstretched hand and dislocating the lunate bone. That can decrease the volume and increase the pressure in the tunnel. Also an abnormal thick transverse carpal ligament. That can put more pressure down as well. That can all produce carpal tunnel. Now, distal to the injury is where you're going to get the effects. So in addition to thumb dysfunction, and thus hand dysfunction, since your thumb's your most important digit, you can also, it can affect the lateral 2 lumbricals, but you're not going to see any atrophy in the lumbricals. You're going to see it in the thenar region. You can see how plush this is here. So if you have a bad enough injury over a prolonged period of time, the thenar muscles can atrophy and flatten out, and now you have what's called ape hand deformity. A flat hand resembles an ape's hand. So that's ape hand deformity, positive sign for carpal tunnel syndrome. Some other signs you can do is you can tap over the median nerve. If it's irritated in the carpal tunnel, you can just tap just lateral to the central wrist over the flexor retinaculum. A little bit of compression would irritate it even more, and that could send abnormal sensation down into the lateral 3.5 fingers. That's the Tunnel sign for carpal tunnel that you can also use in addition to Phelan's test. Now remember, the finger flexors from the superficialis and profundus are intact in a low nerve lesion. But in a high nerve lesion, it can affect everything. So one of the tests you can do in a high nerve lesion is you can have the patient hold their hand like this and tell them to make a fist. When they go to make a fist, only these medial 2 fingers go down, because these medial 2 fingers are innervated by the ulnar nerve, the flexor digitorum profundus. The medial half is ulnar nerves. So it can pull those fingers down. But these 3 fingers, you get the superficialis and the profundus and the flexor pollicis longus. If they're all completely paralyzed, you won't be able to move. That's called the hand of benediction sign. So this is more you're likely to see in a high nerve lesion in the arm, but not with a low nerve lesion at the wrist in carpal tunnel. Now, if we finish this, you follow the nerve. The median nerve is going to go through the carpal tunnel, and then it's going to have 2 branches. One's going to be the recurrent branch, motor branch only, sometimes called the thenar branch. It's going to loop around the lateral distal flexor retinaculum, become somewhat superficial at that point, and then go deep into the thenar muscles, those 3 muscles. Actually, it's only 2.5 of the muscles. It's only going to get the superficial part of the flexor pollicis brevis. So that can cause atrophy of the muscles and dysfunction, like we talked about. And then the other branch, other than that, is the lateral and medial palmar digital branches. They're both motor and sensory. The motor function, the lateral branch innervates the first lumbrical on the index finger. The medial branch innervates the second lumbrical of the middle finger. So again, that produces that flexion of the MCP joint and extension of pip and dep that we talked about. And then the remaining of the palmar digital branches are sensory. So they're going to innervate the lateral 3.5 fingers. Remember, the central palm and the lateral palm have already been innervated by the palmar cutaneous nerve up here. So it's spared in carpal tunnel syndrome, like we said. So that's a summary of the structure, function, and pathology of the median nerve.